And let me just touch on a couple additional cost things, and I want to move on and dig into training a little bit more. But Brad, a few listeners brought up the question of costs. We believe DCTs will cost less than traditional trials. That's the thing I've been hearing. But they do require the implementation of expensive technologies. So a few people asked if they really cost less than traditional trials. Now, I know Medable did a study recently, which was presented by, I think, Ken Getz at DIA a couple months ago, that showed they are cost effective. But here again, there's so many variables involved. I'd love to hear from the site perspective. Do you believe trials are really seeing cost benefits from DCTs and hybrid trials at this point in time?
I mean, I think it's hard to say because I think there's a lot of sort of opacity still with this whole movement, if you want to call it that. So I did see a little bit about that, a little bit of that paper. It didn't really lay it out clear enough for me to be able to make that conclusion. I'm sure they had some numbers to prove that, but I'm not so sure. Again, that's going to be the case, and I think it may depend on how intelligently these things are implemented and the types of trials that they run across. Because I mean, I don't know how it could be more cost effective to have home health on call across the country at all times. I don't know. So again, that's not clear to me yet at this point from the bigger perspective. I think that'll be still something to play out a little bit more.
Carrie, anything you wanted?
Yeah, Brad, I would totally agree. I think when we say DCT, I think everyone just jumps to 100% DCT. And what I loved about that initial study we did was like, what parts of it are the benefits? What parts are actually going to increase the costs? What parts do patients want? And so I think there are components of DCT that are sure cost effective, going to improve the experience. I would actually challenge these systems to actually be even more intelligent, to actually provide more information to not just patients or to sponsors, but to sites to be able to make better decisions. But then there's elements like the direct to patient. I know when we deployed it, we had to think about sending 2 staff from a safety perspective. So there's time for driving to and from, so less time on a site, insurance that we had to deploy. So I can imagine, again, a vendor with how hard it is to find nurses right now, again, to Brad's point, across an entire nation. How do you really provide that direct to patient? And how does that actually improve costs compared to the traditional site model where the patient's coming to you? Telehealth, remote visits, certainly cost effective for all. So that would certainly improve the costs. And then maybe that's what should be deployed.
And I've heard a lot of discussion recently about site costs escalating, especially post-pandemic. I don't know if you guys agree with that or if you disagree with it, but folks have been telling me they've definitely seen sometimes, in some cases, tasks being performed by sites now being 3 times what they were just a couple of years ago. It's being blamed somewhat on salaries going up, people leaving the industry, staff shortages, the challenges of hiring folks and having to pay them more. And of course, we had a lot of studies that were maybe paused or delayed during the pandemic, which are now coming back online along with all of the new trials that are starting, that increase in demand. It's almost like a perfect storm coming together at one time that's impacting costs. But then that makes me wonder as well, is this move to decentralized trials that's happened the last couple of years, is that adding to it as well? Either of you want to take a shot at that one?
Yeah, I mean, I think to some degree, I mean, to address at least some of the staffing issues, I mean, I think potentially you're looking at staffing different people with different skills than you would have normally, which again is going to have some increased costs, especially if you don't have that skill set already on your team. To your point, inflation is affecting all of us, and as a site, you're oftentimes it feels oftentimes sites sit sort of at the bottom of the food chain. So a lot of your coordinators they're looking to get out, right? They want to go up to a CRO, become a CRA, make the big bucks and travel around. So, you want to be able to take good care of your coordinators to keep them with you, because again, those are huge problems. Turnover is a huge problem at the site level. Not that it's not in other areas, but I think it's particularly sensitive at the site issue. So, yeah, I mean, I think in order to continue to retain talent and also get the right people, we're looking now for people who are more tech oriented, as to where maybe your staff was previously LPNs. You're looking at having to bring in a whole different skill set, which is gonna cost you. So I think that's certainly a nuance that maybe hasn't been talked about a whole lot.
I would
And
say,
Brad,
yeah,
I'm
yeah,
sorry,
sorry.
go
I would
ahead.
just add to that. The majority of sites costs really are payroll. And so there's no doubt our payrolls have increased, and mostly attributed to having to increase cost due to inflation and, retention strategies, losing people to companies that are paying a higher premium. So traditionally pharma and CRO. So that is probably the biggest impact, but I would also say having to hire the additional staff to support the work. So a smart site that can evolve with this change and transition will hopefully find maybe a coordinator that was a nurse doing some of the data entry won't have to do the data entry more. So you find data entry type level staff that you can maybe pay at a lower premium, and create a system that basically supports that. So I think you just like the sites are going to evolve into a different kind of format than the traditional coordinator doing all of the work. It's the only way for sustainability, to be honest with you.